Thank you. Very happy to see everybody here. The agenda for today will be quite extensive. We'll be seeing three nice cases: PCI in a diabetic patient, PCI in a high bleeding risk patient, and PCI in a very complex patient. I've seen our cases and prepared some interesting questions for the presenters, and hopefully generate some real good talk and discussion about this. But first of all, I'd like to ask Professor Sardella to give us an overview on the Cre8 family and clinical studies and the update of this. Professor Sardella, please.
Good morning to everybody. Thank you for your introduction. I will start the presentation. Okay. This is my disclosure. Thus, we have to introduce, first of all, the four important features of the Cre8 Evo, the polymer-free amphilimous eluting stent. The first important and exclusive feature is the Alvimedica reservoir technology, and then the amphilimous formulation, sirolimus plus fatty acid, that is really unique in this field, the bioinducer surface, and the Evenard stent architecture. The Alvimedica reservoir technology is a proprietary polymer-free drug release system constituted by reservoirs on stent's outer surface. And we can see that the arterial wall, the drug elution, is controlled and directed exclusively towards the vessel wall. And on the other hand, the blood flow, there's no polymer and no drug. And you can see the Cre8 compared with the other stent, the peak drug tissue concentration during the first days. 50% of drug elution in approximately 18 days and up to 70% of drug elution within 30 days and the complete drug elution within 90 days. The second important feature that shows that the Cre8 is the only DES in the world releasing this formulation. It's really a formulation with sirolimus and fatty acid, and you can see in light blue the fatty acid around, like a flower, around the corolla of the flower that is sirolimus in dark blue. And the sirolimus and fatty acids are eluted together, and they have a combined effect. We can see what happened in diabetic cells. We know that in non-diabetic cells, we have two different pathways for ATP generation. The glucose pathway, 30%, and the fatty acid pathway, 70%. On the other hand, in the diabetic cell, we have only one pathway. The membrane protein overexpression leads to higher fatty acids binding translocation. You can see only is binded by fatty acid 100%. And for this reason, it's very important this formulation that act as a Trojan horse-like effect. The limus drug and fatty acid together can favor the higher sirolimus presence inside the diabetic cells. We know that there is a direct resistance of vessel smooth muscle cell to limus drugs. 10 times higher limus concentration is needed in diabetic patient cells to achieve a similar inhibition. And for this reason, we know that the latest generation DES as Resolute Medtronic or X-Science or Zero versus X-Science have not been able to improve outcomes of diabetic versus non-diabetic patients. You can see they have the same efficacy in diabetic and non-diabetic between the different DES. The third important feature is the bioinducer surface. The bioinducer surface is an ultra-thin pure carbon coating that is integrally applied to the Cre8 Evo, very thin platform, 70 to 80 millimicron before the drug loading. And last but not least, the MNR stent architecture. It was changed by the Cre8. We can have two important technical improvement. The radiopath markers, Cre8 Evo has highly visible platinum markers at both stent ends. And the other thing is that no foreshortening, that the Cre8 Evo stent design has no foreshortening upon the expansion. Thus, the radiopath markers plus the no foreshortening allow a precise DES implantation, in particular in ostial lesion, in long lesion, where we have to cover a long segment of the vessel, and in bifurcation lesion. And we can see the comparison of strut thickness with the other stent. We can see the Cre8 Evo for small vessel. It's almost the thinnest stent, so as well the Cre8 Evo mean vessel and large vessel, compared with the other stent, and compared with the other stent like Orsiro that have very thin struts. What about the clinical proof? We have several studies in terms of safety and in terms of efficacy. In terms of safety regarding the short apt, in terms of efficacy regarding in particular diabetic patients. For the efficacy, we have an angiographic instant late lumen loss at 6 and 9 months as primary endpoint with this study. Next study, participate and reservoir, and a matched analysis that I will show later. The first study, the reservoir, in an OCT randomized controlled trial study. The primary endpoint was a no-intimal volume obstruction assessed by OCT at 9 months, comparing Cre8 versus X-Science. You can see at the 9 months, the Cre8 has less than 25% respect of X-Science, and the primary non-endpoint was met for non-inferiority 0.0003. For the reservoir OCT sub-study, it is very important. It specified subgroup analysis that involved the hemoglycosin, the patient with hemoglycosin, and you can see the interaction between the stent type effect and the metabolic control assessed by the hemoglycate. What about the three different studies in terms of the stent late lumen loss? The reservoir, the participate, and the next. They are three different studies, three different core labs, but the outcome, it was equivalent. You can see 0.14, 0.16, and 0.12 versus 0.14 in the next. Thus, we have the same result with different study and different design of the study and different core lab. And this is a pooled randomized controlled analysis at 3 years in diabetes mellitus patient. You can see that the results of TLR of a pooling analysis. You can see the X-Science versus Taxus and Resolute in blue, the Cre8, less than 40% at 1 year, less than 44% at 2 years, and less than 70% at 3 years, with a quite significant difference between Cre8 and all the other new DES. And this is a very important matched analysis, Cre8 versus biodegradable polymer, the no-body stent, the Astute registry regarding Cre8 versus the Inspire registry. And we can add two different analyses, the non-diabetic mellitus cohort, where we can see less 17% regarding the TLF and less than 50% 4 versus 2 in TLR. That is Cre8, it was always numerically better than Nobori. And what is very, very interesting, the diabetic cohort, it was much better, the results in terms of TLF and TLR. In favor of Cre8, you can see less 62% of TLF and less 56% of the TLR. That you can say that you can see that in diabetic cohort, the results and the efficacy of Cre8, it was much better than this non-diabetes mellitus cohort. And this is the sugar trial that the multicenter randomized in all-comer diabetes mellitus patient. It's a Spanish study, 26 Spanish sites. The primary endpoint, it would be the TLF at 1 year, and co-primary endpoint, TLF at 2 years. And they compared Cre8, Evo versus Onyx, and it was submitted. We hope accepted a late-break clinical trials at the next TCT in Orlando. What about the safety? The safety considered the death strat coverage at 1 month up, in terms of 1 month up in daily clinical practice. And we will see in high bleeding risk patients, that's in frail, very frail patients. Two very important studies was demonstrate and the recreate. What about demonstrate? Demonstrate control trial compare the Cre8 versus the bare metal stents by Abbott, the chromocobalto stent, and the primary endpoint was the Cre8 percentage of section with root score less than 30% at 3 months. It was non-inferior to bare metal stent percentage at 1 month. You can see the root score. It was quite similar between the Cre8 and the bare metal stent. But what is very important is the secondary endpoint, the median intima thickness, it was less than 56% in Cre8 versus the opposite, it was the bare metal stent. The Cre8 study that was presented at the late-breaking trial in TCT and 2.0 in 2018, it compared Cre8 versus durable polymer ZES, the Onyx stent. The primary endpoint was the target lesion failure at 12 months. And we see it was a very, really all-comer study, 20% of patients with diabetes mellitus, quite 58% with a very complex lesion, B2C, and bifurcation 19%. What is very important was stent length. It was the only study with more than 40 millimeters of stent length, quite 50 millimeters, 47 plus or less 21 in the two group of patients, the two group of stent. You can see the target lesion failure, it was quite similar between Cre8 and Resolute. But what is very important, the primary non-inferiority endpoint was met, of course. And you can see the 1 month up sub-study, that's the safety of the study. You can see the Cre8 has 50% lower stent thrombosis after duct interruption after 1 month, that the late stent thrombosis was 0.45 versus 0.90. That it was a device-related stent thrombosis that is quite 50% lower in Cre8 Evo stent after 1 month. Thus, we can talk about the high bleeding risk patients that are at high risk of both bleeding and ischemic events, not only safety, but always efficacy. You can see that almost 50% of patients in all the PCI studies satisfy the ARC HBR criteria. And you can see that in this patient, the 1 year event rates, it was much more than the non-ARC HBR patients. Of course, diabetes is one of the most frequent comorbidities in high bleeding risk patients. And the prevalence of diabetes in high bleeding risk patients is up to double versus that in non-HBR patients. Thus, we have to consider that the PCI efficacy and bleeding are an interconnected equation. Why? Because the 50% or even more in the first month after PCI are bleeding events. The remaining 50% occurs in the following 11 months. Thus, if we compare a standard death at 1 month after versus highly superior effective death, thus we have to take into account the efficacy, not only the safety at 1 month after. What we could have a stopped up at 1 month in the 2 different stents, highly effective and effective. But after that, we continue with ASA in the highly effective DES. What could happen if the DES is less effective? That at this point, after 1 month, we have to re-PCI the patient. And for this reason, we have to restart the double anti-aggregation therapy. Thus, we have a double higher bleeding risk. Thus, we have to stop DAPT and to restart with ASA. For this reason, we have to consider that efficacy and bleeding are an interconnected equation that we cannot take into account only the efficacy or only the safety. On effective recreate sub-study in diabetes mellitus patients analysis, we can have a clinical result at 3 years. TLF in Resolute versus Cre8, you can see the difference. The lower overall events, 12.5 versus 10, mainly achieved in the first 1 or 2 years. And the TLR, Resolute versus Cre8, you can see the TLR events reduction in diabetes patients represent the driving factor for Cre8 arm better clinical performance. You can see 6.6 in Resolute and 4.7 in Cre8. We can conclude that the Ablumi reservoir technology of the Creativo is the only one on the market able to precisely control drug elution 2 or 3 months from a thin-strut polymer-free platform. The lack of any polymer avoids those inflammatory triggers provided by the polymeric presence, and the bioinducer surface minimizes the prothrombotic stimuli and promotes a fast tensile coverage. This innovative formulation, sirolimus plus fatty acid, enhance the drug viability and tissue permeability, especially into diabetic cells, and the new Cre8 EVO architecture allows for improved platform performance in challenging lesions. All the randomized control trials and registry performed in diabetics patients have shown superior efficacy of the Alvimedica formulation when it has been compared to other DES of 2nd generation. About the 34 up to 49%, 50% of patients in registry and randomized control trial are at high bleeding risk according to the new HBR classification, meaning that the prevalence of HBR patients in the PCI population could be higher than we think. We absolutely emphasize the Creativo ensures efficacy, in particular in diabetic patients, and safety in terms of very short DAPT in HBR expected and unexpected patients, respecting the concept that PCI efficacy and bleeding is an interconnected equation. Thank you for your attention.
Thank you very much. Very interesting to hear about the new technology. As a user myself, luckily, I was more or less aware of everything that you showed us, but as I said again, it was an extremely helpful coverage of everything. I'll be very excited to hear about the sugar trial at TCT 2021 and see how that will go, because that will be more than interesting. Does anybody from the panel or the attendees have any questions? Nobody? Okay. Moving on then. I'd like to ask Dr. Anton Farkas from Slovakia, from Košice, to present his case. It will be a very interesting case. I've looked at it myself, and I have a few interesting questions afterwards, and hopefully I would like everybody involved to join the discussion. Okay, Dr. Farkas, please.
Okay. First, thank you very much for this meeting, and I would like to show you briefly my very interesting case with the diabetic patient with the complex bifurcation lesions. It is a male, 72 years old, with the history of the chronic coronary syndrome, with diabetes, inflammatory bowel disease, and this patient was admitted as anterior non-ST elevation myocardial infarction to our cardio center. On echo was anterolateral hypokinesia with ejection fraction 45% and with the mild mitral regurgitation. This is the initial injection for the left coronary artery. We can see very tight lesion on the LAD and also on very big diagonal branch. It was Medina 111 and intermedial lesion on third. On the right coronary artery, the finding was good. So I decided for a mini crash in this patient. The LAD and the diagonal branch was wired by cyan blue wire, predilatation with the sapphire 2 Pro balloon, and then diagonal branch was stented with Cre8 Evo 2.5 20 millimeters long, and then crushed by sapphire balloon in LAD, then rewired with pilot wire. But one complication was present now. My wire cyan blue was trapped and knot in the stent. So what now? For me, very good that I have the Cre8 Evo stent, because I use the microcatheter, because with the markers on Evo stent, I very exactly know where is the proximal end of the stent. I put the microcatheter on the proximal end of the stent and pull the trapped wire to the microcatheter and extract it without the fracture, without the complications in this patient. And then after then I can perform mini crash technique in this patient. So through the straps sapphire Pro balloon, and then I put the second Cre8 Evo stent 2.75 26 millimeters in the LAD with very good result. Then perform final kissing with two non-compliant balloon, and on the end the proximal optimization. For me it was very good procedure, because in the bifurcation lesions the markers on Cre8 Evo stents are very useful for my daily practice, because for example, like in this patient with the mini crash, I can do like nano crash, because the positioning of the proximal end is very good, with very good visible markers. And this is the final result for this patient. It looks angiographically very good. And this is the follow-up. Patient was on outpatient visit this week. No angina, no bleeding on the APT. He's waiting for elective IFR guided PCI for the circ. This is postponed to September this year due to COVID era and limited capacity of our cath lab. So patient is stable and waiting for next procedure. For me, to create Evo stent is ideal choice for diabetic patients according to clinical trial data. In case of complex pulmonary lesions, anatomy, and need for dedicated bifurcation technique, also Cre8 Evo in daily practice is very good choice. And I use this stent for many cases like this. And if something's wrong during the procedure, keep calm and try to fix it. In case of trapped wire, very good choice microcatheter, and also the structure and the markers of the Cre8 Evo stent can help you solve this complication. Thank you very much.
Thank you for this case. We've seen many things in conjunction with the case. Let me ask you my first question. It was a very good idea not to simply pull out your trapped wire, because I've had situations in this where you can actually apply force and pull out the wire without any problem. But in the worst case scenario, what happens, the end of the wire gets hung up in the stent and it crushes the stent into a neat little metal ball. And then there's nothing else to do but to go to surgery with the patient. So then again, you lack options afterwards. The microcatheter exchange is really good. Also, I've done it with guide extension tools, so simple guide extension devices without microcatheters, or even a small balloon if you don't have a microcatheter at hand. So 1.2 or 1.25 balloon is also good. What you need to do is give it a bit of a push inside, and then when you see the tip, it will align the wire as you pull it out a bit better, and it rarely happens afterwards that indeed it gets stuck in the stent and then eventually crushes it into a metal ball. Now, my question is regarding the follow-up of this patient. Would you consider IFR in every case with a lesion like this? And I'd like to ask also the other people, would you simply perform any kind of measurements in this circ, or simply proceed with PCI?
In our center, we perform IFR in these lesions very often. For me, it's more than 80% of the patients with this intermediate lesion. It was not culprit lesion, and I perform IFR and then stenting or not stenting.
I see. Does anybody else have an opinion on this?
I have a comment and a question.
Yes.
Congratulations, Anton, for the choice of the microcatheter. It's very interesting option. We know that in the bifurcation lesion, as I showed before, the two marks of a Cre8 Evo, of course, it's very helpful for us. But do you think that the resolving this case, the Cre8 Evo, have helped you for the new structure of the struts, or you think that it was not important the kind of DES that you used?
For me, it's not important. I am very familiar with Cre8 Evo stent, and I have no problem with the bifurcation lesions, and no problem with the CTO patients. So for me, it's a stent of the choice. Yeah. For me, the structure, architecture of the stent in this stent is not very important. Because,
No. I asked you this because I don't know in your experience, but I noted that with the Cre8 Evo, for instance, when I perform a pot, it's more feasible with the new structure of the desk. I mean, compare the Creativo with the old Cre8. I noted that is in this stent, just for the different structure of the struts, the pot, for instance, it's easier. I don't know if your experience is the same or not.
Yes.
Okay, Dr. Aradi, please raise your hand.
Yes, I also congratulate Anton for this great case. We all know that we try to keep it simple in bifurcations, but in this case, you needed to select the two-stent strategy with crash. We know good short-term results, but quite poor long-term results, restenosis. Do you think Creativo can tackle this for the long runs? Do you have experience for crash stenting with Cre8 to have lower instant restenosis? And just a remark, I also think that final pot is crucial in all of these techniques after kissing. Just pay attention to the distal marker because it's the perfect solution when it's not distal to the carina. Thank you.
Thank you very much. Yes, I have experience with Creativo stent in bifurcation lesions in my patients. I have some patients also with left main stented with Creativo stent with IVUS after the stenting and with the coronarography after the 6 months. I have patients after the 2 years after the stenting of the left main with the Creativo stent. And I think that when you perform your procedure with good post-dilatation, with good pot, I think that restenosis is very, very low in this stent.
Yes, I also thank you for the answer. I also tend to agree. And there is another thought regarding this. When performing bifurcation PCI, especially two-stent techniques, especially TAP, so tap techniques, which is quite commonly used in Europe, you need a stent that the visibility and the edge of the stent is quite well to be seen. The Creativo helps us with the fact that the marker on the stent is the absolute end of the stent, so we have the possibility to place it as perfectly as possible. Even competitor stents that do not necessarily have a marker, the problem is that usually there is a gap in between the marker of the balloon and the stent itself. And this gap varies from product to product. And either you use very high amounts of radiation to visualize your exact position of the stent and not only the balloon marker, which is of course bad for you and for the patient, or you can use the device that has a very nice visibility in this accord. So again, I'd like to congratulate you for the case. And because of this crush technique that you used, would you consider any alteration in the patient's DAPT duration or either the medication given?
This was a patient with acute coronary syndrome. So now he is on DAPT for 1 year. But I think that in case of problem, in case of bleeding, it's a safe stop the DAPT. I think also in the 1 month, in this case, in this bifurcation lesions with good implanted Creativo stent. I'm not afraid about this.
Yeah, I wouldn't be either. I have to agree with you. Thank you for your answer. And again, I'd like to invite everybody to ask their questions. If I understand, we have some colleagues from Serbia also here. If you have anything to share with us, please let us know, because we're quite interested in your point of view and how you solve these situations at hand. You can also please write to the chat if anybody has any questions, and then I will post them. But so far I see nothing. Okay, let's move forward then. The second case will be presented by my colleague and dear friend, Dr. Aradi. Please, Daniel, let's have a look at your case, and I will mute myself.
Okay, thank you, Istvan, dear friends. Yeah, it's really an honor to be here today. So my case is about a high bleeding risk patient, and we all know that according to Professor Sardella's presentation, they are very common in our practice. So dealing with high bleeding risk patients is really an everyday challenge. So my patient is a female patient who is 75 years old, average obesity, and she has type 2 diabetes, hypertension, and hyperlipidemia. She didn't have any previous MI or previous PCI. So this is the first presentation to a hospital due to an acute coronary syndrome, which was last year, November 30. She presented to our unit due to a non-STEMI. We saw diffuse ST depression in the ECG in leads V3, V6, and with an ST elevation AVR. In the labs, we had an elevated troponin that showed a upgoing kinetic and slight anemia and a moderately reduced kidney function, reflecting chronic kidney disease. On the echo, she had 40% ejection fraction with an inferior akinesis and posterolateral mid-septal hypokinesis. On the presentation, she received from the ambulance aspirin, clopidogrel, and some nitrate oxygen. And due to non-STEMI, high-risk troponin positivity, and chest pain, we performed the angio. So here you see the angio, what we suspected also from the ECG, diffuse three-vessel disease with a critical stenosis in the left main. We can see the RCA is filling back retrogradely, and there is a TIMI1 flow through a critical stenosis in RCA. Also, we see that there is a significant but not critical lesion in proximal circ and LAD. So we all know that this is a difficult situation, but the patient has persisting chest pain, non-STEMI, elevating troponin levels without on-site surgery. We need to help the patient, so we decided to go with the PCI. So to help the left main PCI, we tried to first stabilize the RCA, and it went well. We pre-dilated after wire crossing and then implanted Cre8 Evo 275-26. You can see the distal markers of the Cre8 Evo showing some residual stenosis due to the highly calcified lesion that was post-dilated with an NC balloon with very high pressures. And we had an acceptable result with some under-expansion due to the very highly calcified lesions. And then we proceeded to the left main PCI. We selected a crossover technique, first 3.0 by 12 synergy in proximal LAD. And due to the high discrepancy of the vessel sizes, we put a 4.020 synergy megatron. And that was first kissed with two balloons and then a pot of 4.5 in the bifurcation. We see some residual stenosis in the orifice of the circ, but after this PCI, complex PCI, we was happy to stabilize the patient, and this was the acute final result. So we have a patient who is 75 years of age, so 1 point for the age. She had moderate renal disease and also slight anemia. If you check for the recent ARC HBR criteria, this patient received 3 points. And if you have 3 minor points, this is really an HBR patient. But life is not so simple because this is really a complex PCI. So if you do a stratification for coronary thrombotic risk, you see that we have also many risk factors for thrombosis. So this patient is a diabetic patient. We had multivessel coronary disease. We have also chronic kidney disease. We implanted 3 stents and treated 3 lesions. So Yes, without being an interventional cardiologist, I think all of us know that this is really a complex case, which is really a high thrombotic risk patients as well. So as Professor Sardella told, bleeding and thrombosis go in many cases hand by hand, and how to handle these patients is really challenging. If you check the current guidelines, the non-STEMI guidelines for 2020, you see that if the patient has high bleeding risk, we should try to avoid very long durations of DAPT. And according to the guidelines, you see that only 1 to 3 months of DAPT with aspirin and clopidogrel and then aspirin alone. However, we have another options, which is in the guidelines for low bleeding risk, but I try to defend that this is not the real best option, because here the angle shows you that if the ischemic risk increases, this may be an option for those high-risk patients who have also high bleeding risk and high thrombotic risk. Stop aspirin and not the P2Y12 inhibitor, because this strategy has been tested in recent trials, 2 randomized controlled trials, and it showed the reduction in bleeding events without compromising efficacy. So to our patient with left main and RCA PCI, but also with high bleeding risk, we selected this strategy. So 3 months DAPT, aspirin and ticagrelor, and then stop aspirin and not ticagrelor to prevent any stent thrombosis. We had a follow-up angio at. What you see is that in the LAD, proximal LAD, the stent is okay. However, in the synergy, you see some focal restenosis just before the bifurcation. In the right coronary artery, where the TIVO was implanted, despite the under-expansions in the highly calcified lesions, it looks very nice without real instant restenosis. So we did a DAB treatment for the left main to prevent further late loss. So I just tried to bring you a case about high bleeding risk that is really frequent in everyday practice, but I acknowledge that they require individualized antiplatelet therapy. However, many HBR patients have also high thrombotic risk, and this needs to be reflected in PCI technique and stent selection, and also in the antiplatelet therapy. And I agree that high bleeding risk patients may benefit from shorter DAPT, but current evidence suggests that there is also a strategy by stopping not aspirin, not the P2Y12 inhibitor, but aspirin, and this may be a good strategy for HBR plus HTR patients. And in our current case, the Cre8 demonstrated good safety and efficacy despite the shorter duration of DAPT. So thank you very much for your kind attention.
Thank you, Professor Aradi. I think that Édes and Anton will be on the screen, on live. For now, I have just one question for you and one comment. If Édes, okay, waiting, looking forward at Édes. I have just one comment and one question. The case is great. Really great case, really great case, because it showed that they interconnected the question between safety and efficacy. But just one comment, it was very calcified lesion, and why you didn't use the rotational atherectomy, so shockwave or something like that. This is the first comment. And the question is why you chose two different kind of stents, before the Cre8 and then the synergy, and not only one stent in the 2 procedures.
Yeah, thank you, Professor Sardella. Regarding rotablation, you know, in many cases, the physicians are smart afterwards. Maybe it would have been better to start with rotablation, but after the first successful predilation, I saw that the lesion may be responding to a normal predilation. However, when we have put the stent inside and tried to reach the nominal size of the vessel, then we realized that maybe it's not enough. However, in this emergency case, you know, restoring flow is the first thing to do, and I was happy to restore the flow in the RCA. regarding your second question, I hope you hear me because...
No, we hear you, but we don't see you, but it's okay. We hear you very well.
Oh, great. So the second question is why I chose different type of stents. You know, my choice of stents for the left main was because of the potential to post-dilate the new Megatron family at a very, very high level. So from 3.5, you can go up to 5 or even 6. And I didn't want to distort this strategy and stent structure that the Cre8 has. So the reason to choose the Megatron in the left main was to have an opportunity to post-dilate even 2 sizes bigger than the proximal LAD.
Yes, thank you, Dr. Sardella, for stepping in. I would have posed the same questions to Donny. I have to agree with him that in this case, I also would have probably used a specific left main oriented stent because of the fact that, as was discussed, it can be overexpanded to more than twice or almost twice its size. Albeit I do also, I would have considered rotational atherectomy or at least a cutting balloon or something in this case. But you know, after seeing a case when we're in nice air-conditioned rooms is very easy, and studying SmartPros is also very easy. When you're sweating in the cath lab at the patient's table, you know, as you yourself know, that's a whole different story. And I do have to congratulate Dr. Aradi for this case because he has no on-site surgery. This was a case of saving the life of the patient, which was indeed successful. And I also have a question to everybody. With your practice, let's say you have surgery available, would your surgeons have handled this acute case? Let me start by answering my question as well. Our surgeons, you know, we can rely sadly less and less on surgeons, even if everything is there for acute surgery and every guideline says that the patient would benefit best from surgery. There is always an issue that is eventually found by our surgeons, and we get most of them referred back to the cath lab either immediately or within a couple of days. And Dr. Sardella, how is it with you?
I think that when we have an STEMI and acute coronary syndrome, it's difficult to even in this case, the first difficult thing is to analyze and to understand the culprit lesion. And for this reason, in effect, when you have a triple vessel disease, for this reason, this is a great case because it's not easy because you have to make, sometimes you have to make all in one step. This is not very easy, and sometimes it's not suggested. But when you don't know where is the culprit, which is the really culprit lesion, you are forced to make all in one in one step. For this reason, I think that this is a very learning case.
May I have a question? I would like to ask the company, maybe Enrico is still there. So Enrico, Cre8 has a unique reservoir technology. And as we all know, this reservoir is designed as the size to control the elution kinetics. So you control the elution by sizing these reservoirs. So what happens if you over-dilate Cre8 Evo by, let's say, 1 millimeter, 1.5 millimeter more? Won't you distort these reservoirs?
Well, thank you for the question and the opportunity to clarify that the position of the reservoir on the entire surface of the stent has been placed where the deformation due to the expansion is not going to affect size or positioning. So because of this, the reservoir is where the strut will not be changed during expansion, flexion, or torsion. And that's the reason why a post-dilation is not affecting at all the kinetic. because the risk kinetic is fixed by the shape of the reservoir in section. And as this is not going to be distorted by the overexpansion, the risk kinetic will be the same for a stent, for example, like the 3.5 or 4.0, okay, if they are expanded at 4, for example, or if they are expanded up to the limit that is for 5.5, okay. So this is not going to be done, and this has been done on purpose to allow to have the best possible mechanical performance of the stent. In case of Creativo, I want to underline that the family Creativo is composed by 3 different type of stents. One for small vessels, one for medium, and one for large vessels. And this has been done on purpose to try to have, you know, the behavior of the stent and the mechanical performance at the maximum. But once again, you know, it's important that where the reservoirs are placed, any expansion or expansion, dilation for the side branch will not affect the reservoir itself to keep the elution kinetic lasting up to 3 months for the best possible efficacy in diabetic patients and in all the patients.
Thank you.
Just one thought to this end. I'd like to congratulate the company because there are rarely stent makers anymore, stent producers, who use 3 platforms for the whole portfolio. Usually it's only 2 nowadays, so the major competitors, they use 2. So 1 for small and medium and 1 for large, usually. Okay, I see that time is setting, so I'd like to go to the last case, which is that of Professor Sardella.
Thank you. And I will be fast. This is the my disclosure. What is a complex patient? We know the complex patient. We can define complex patient according to clinical complexity, and we can define with according to anatomical complexity. And we know the clinical outcome according to PCI complexity is very different. You can see the difference between non-complex patient and complex patient, non-complex PCI and complex PCI. For this reason, we have to take in account the complex patient as a very different feature of patient. My case, it's about a 78-year-old male with hypertension, diabetes type 2, smoker, peripheral artery disease, and the patient did surgery for a surgical aortic valve replacement with Sortiva prosthesis in 1998. According to the new ARC criteria, the patient was classified as with 1 minor ARC criteria, just the age. It was non-HBR risk patient. The patient status at the hospitalization was a stable angina, cardiac class grading scale 3, and the echo is showed the left ventricular normal size with hypertrophy and a good ejection fraction, and a PAPS Doppler estimated 35 millimeter. This is the basal core angiography. You can see it was a very complex patient with a stenosis at the right and the proximal and ostial LAD, and you can see all the right coronary artery. It was diseased from the very calcified lesion from the proximal and distal part of the coronary artery. The score for decision making, you can see the SINTA scores were 45. It's a very high SINTA score, and we can, if we see the new SINTA score 2, it was the 39, 14.3% and 15.2 cabbage or PCI, and 52.3% in terms of SINTA score 2020, the new overview 10-year mortality. The surgeon in this case refused to treat the patient due to previous surgery, but always the patient refused the surgical procedure for the same reason, because it was already treated by surgery for the aortic valve. That it was be considered a cheap PCI, that a complex PCI, we performed the rotablator in on calcified lesion on LAD with a bar 1.75 millimeters. And we implanted 1, 2, 3, and 4 Creativo stent, 3.3 for 60 millimeter, 2.75 for 9. A Creativo 4 with a provisional double stenting in the ostial LAD with a creativo 3.3 for 20 millimeter. It was the very good final result for the left coronary artery. This was the IVUS. You can see the good result in terms of side branch access. And the same procedure for right coronary artery. We used the rotablator. And we, due to the calcified lesion, we implanted two creativo stent, 3 for 40 millimeter and 3.5 for 16 millimeters with this very good final result. Thus, we consider the score for validation of that duration. We can see that ischemic, thrombotic, and bleeding risk, it was quite similar. For this reason, we consider a cardioaspirin and copidol 17.5 milligram for 6 months DAPT in consideration of the normal bleeding risk and high complex PCI and high ischemic risk. But the surprise, it was the unexpected dramatic event. This was an unexpected case of high bleeding risk. And 15 days later, an hepatocarcinoma was diagnosed by a total body CT scan. You can see the mass in the liver. For this reason, we was forced to interrupt the DAPT because the status of the patient shifted from non-high bleeding risk to high bleeding risk. In this case, there was only one minor criteria, it was age, but in this case, you can see it was a liver disease and active cancer. For this reason, 2 main and 1 minor, it was the patient shifted to the status of high bleeding risk. For this reason, we stopped, the copidol was stopped after 1 month, the cardioaspirin was continued and suspended 48 hours before surgery, according with the surgeon. And after 5 days from the suspension of clopidogrel, the hepatocarcinoma was removed. The cardioaspirin was resumed after 5 days later, and currently the patient is on single antiplatter therapy. And we perform a 3 months follow-up angio because 3 months later the patient experienced the chest pain. But we showed that it was not DES procedural related issue because the final results were completely maintained. And what is very easy, the 3 months OCT, can show that almost complete struts endothelialization of the vessel. You can see in the 3D OCT, you can see here too. And after 24 months, we performed an angio follow-up that showed that it was the good result, it was maintained. And again, in 24 months, OCT showed a complete struts endothelialization. You can see the struts, the ghost of the struts, you can see the almost complete struts endothelialization in this patient. For this reason, my closing remarks for this personal experience was almost 40% of procedures are cheap PCI in my experience, and the high bleeding risk rate is about 50%, of whom the 20-25% true high bleeding risk, 10 and 15% of unknown or unexpected high bleeding risk that more dangerous. And the cheap and high bleeding risk patients rate suggests to strongly consider the bleeding risk as important as it is ischemic risk. Why did I choose the Cre8? I chose in my daily practice Cre8 Evo DES because, in my opinion, the Cre8 Evo stent, beyond the technical features that facilitate the implantation in complex lesions, secures the efficacy, in particular in diabetic patients, and the safety. Thus, you can use the very short DAPT in expected, but more important in unexpected patients, respecting the concept that PCI, efficacy, and bleeding is an interconnected equation. Thank you for your attention.
Thank you very much for this interesting case. I've been lucky that I've seen this for the second time now. It's even more interesting in this case. Seeing unexpected events happening after PCI, especially complex PCI involving rotational atherectomy, left main PCI, multi-vessel PCI, and then afterwards the patient requires major abdominal surgery as well. That's a very, very much unpleasant surprise to have. My question mainly is that how others, the anesthesiologists and the surgeons, did they have any issue with this case, or did they trust your judgment? Because I have to say that we in Hungary do have issues mainly with the surgeons in this case regarding the duration and the type of medication given and how they want to stop it and what our professional opinion is.
As you well know, the anesthesiology and surgeon have always a lot of concerns about all patients, and this is very difficult to treat with them, because sometimes you have to explain why they have to stop, they have to interrupt, and sometimes they need to interrupt, sometimes they try don't interrupt. What is very interesting in this case, as the surgeon and anesthesiologist were forced to make surgery in this patient for the carcinoma, we did a round table with them, and I convinced them that with this kind of stent, this stent it's available, it is allowed to interrupt the double anti-aggregation therapy. I mean, without this stent, they are forced to interrupt, but with this stent, we can interrupt it with, it's easier, and it's more deontological. Because this stent, it was as an evidence-based medicine about the early interruption of double anti-aggregation therapy. And what is very interesting, for 48 hours, this patient, it was without any anti-aggregation therapy, no aspirin, no clopidogrel. And after that, it restart the single anti-aggregation therapy. I think that it's very important to have a safe stent, and a stent that it was tested by the evidence-based medicine and by the registry and by the clinical trials, that you can show to the other colleagues that unfortunately they don't know our problems with this stent, but it's easier for us to have an interconnection with them, and to have a link with them, and to make a round table with them.
Yes, thank you very much for your thoughts. I see that Dr. Aradi has a question.
Yeah, I also congratulate you on this great case. I have to say that the patient was really lucky, and you did a perfect job, because indeed we know that we can stop the double antiplatelet treatment in most of the cases in such patients with very long stented segments, double vessel treated, stent thrombosis risk is still very high.
Yeah.
And in our practice, we try to force the surgeons to operate on aspirin in such cases. However, I know that maybe this carcinoma had a high bleeding tendency, so neurological problems, operations, and very high risk cancer operations, still aspirin also needs to be stopped. But in most of the cases in such patients, we try to force surgeons to operate on aspirin, and I can say that most of the hip surgeries and other surgeries are done on aspirin without severe problems. So thank you.
What is it, just one comment? In Italy, it's difficult to convince this always and also the dentist to stop aspirin.
That's same in Hungary.
because you think, but it's so difficult to convince a surgeon before a liver cancer. It was very, very, very difficult.
Yes, thank you very much. I have one question, Dr. Sardella. First, a remark. I'd like to point out to everybody that we've been discussing the newer generation of Cre8 Evo stent, but please also be aware that the older generation of the Cre8 device has also the same proven efficacy and safety in both HBR and diabetic patients. So that you also must be aware of if the new Cre8 Evo is not available for everyone. My other question is, when handling calcified lesions like this, I'm very much into intravascular imaging, and then afterwards deciding mostly on the calcific arch that you see if it's below or under 180 degrees on how to go forward. And eventually with left main stenting, I also like to perform an IBIS whenever possible to assess these results. How is your standing on this, Professor Sardella?
I fully agree with you with the first comment. And the second comment, I'm used in our hospital, in our daily practice. Believe me, we don't care so much about the distribution of the calcium. When we see a very calcified lesion, we start at first intention with rod ablation. Now we have available a Shockwave 2, and from 1 month the orbital atherectomy, that it's very good option, another very good option. We are just started to use it, but I mean rotational atherectomy or Shockwave, I think that as first intention we don't lose so much time with the cutting balloon or very non-compliant balloon. We start directly as first intention with atherectomy, a lesion preparation with one of these devices that we have available in our cath lab.
I see. Thank you very much. Does anybody else have any question or comment regarding anything during this case? If not, then it's time for closing remarks. I also see we went a couple of minutes overboard, but they were very interesting cases. I'd like to congratulate all three of my panelist colleagues for their very interesting and also technically challenging and provocative cases that we've seen. I think the discussion was also very much at hand. And to summarize everything, I'd like to state that everybody who's in the cath lab today performing coronary interventions has to know and has to understand that we will be handling more and more difficult cases as the years and months progress. We can rely less and less on surgery and the heart surgeons themselves because of the fact that most of the patients that we will be needing to treat are simply not viable for surgery. And also, please understand that high bleeding risk and high thrombotic risk go hand in hand. So if the patient is high bleeding risk, then most likely that patient will also be very high thrombotic risk because, as you well know, the parameters for one and the other overlap in the equation. And as Professor Sardella put it very, very keenly, you have to understand that these things go hand in hand. And thank you very much for everybody's attention. I'd like to thank our sponsors for this possibility. And please also remember that the device that was talked about today, the Cre8 Evo stent and the older Cre8 stent, is very much efficacious in diabetic patients and also in high bleeding risk individuals. If you choose this for such patients, you're absolutely performing a good job and planning for a long-term future of this patient. Thank you very much again for my panelist colleagues and everybody for paying attention, and enjoy your summer. Thank you.
Thank you. Bye.
Thank you very much. Have a nice day. Bye.